Hi, I'm Jack Takahashi, and we're going to review the reproductive hormones and in the process, learn about IVF. First, let's just remind ourselves that LH and FSH are gonadotropins. That word means that they're tropic to the gonads. They stimulate the gonads, testes in men, ovaries in women. Now let's take a look at this graph that you've seen probably since high school. The first thing I want to say is that if this graph is confusing to you, if you have a hard time remembering how it goes, this is completely normal. There's a lot going on here. There's 4 different hormones. Most of it is not intuitive when you think about it. And a lot of what's going on here is not even understood by science. Here's the main takeaways I want you to have. First is that follicle stimulating hormone stimulates the follicles. You see higher levels of it during the follicular phase. This is the gonadotropin that really drives the ovaries to mature these follicles. The second thing to remember is that ovulation is triggered by the LH surge. Don't worry about the FSH levels peaking as well. It's the LH surge that drives ovulation. The third thing to remember is that the relationship between estrogen and the LH and FSH is a switcheroo. At first, there's negative feedback where the estrogen suppresses the levels of LH and FSH, but something happens that we don't understand, and there's a switch so that the estrogen causes positive feedback, which gives you this LH surge. Now, there's just a couple more things you need to know. The first is that estrogen is what builds up the endometrium. That's why the follicular phase is also called the proliferative phase, because the estrogen is driving the proliferation of the lining of the uterus. Progesterone is what matures the lining and makes it really secretory and rich in blood vessels and just ready to pick up an egg, all right? And then the withdrawal of progesterone is what kills the endometrium and causes menstruation. And then the last thing I want you to know about here is that even though the LH levels in the luteal phase seem like they're really low compared to the LH peak, there actually still is some LH here. And this is what stimulates the luteal body to make the progesterone that we need for the luteal phase. That's why it's called luteinizing hormone. The luteinizing hormone supports the luteal body to make this progesterone. Now that we've gone over the main points I want you to remember about the menstrual cycle, I want to show you this. This is my simplified graph of what I really think you should actually remember about all of these hormones and their levels changing throughout the cycle. If you can just remember, FSH is follicle stimulating hormone stimulating the follicles. The LH peak is what triggers ovulation. Progesterone switches the uterus from let's get sperm inside me mode to let's grow a fertilized egg into a baby mode. This is really the most crucial parts of this graph, and if you can remember at least these 3 things, you're in a good place. Now I want to take a quick minute to talk about what happens during pregnancy. Now don't worry, you don't have to learn very much about what actually happens in pregnancy until your 3rd year OB-GYN clerkship. But you probably know that progesterone is called progesterone because it's the progestational hormone. It is the hormone that is necessary for making the uterus support a growing baby. So with that in mind, you'll notice that normally as the luteal body degenerates at the end of the menstrual cycle, our progesterone levels drop, and this is what causes menstruation. This is incompatible with pregnancy. So if our egg gets fertilized and we want it to implant in the uterus and make a baby, we need to make our progesterone levels not only maintain, but actually continue to increase. So what's going to happen in order to make those progesterone levels increase and keep that endometrium in the secretory phase? Well, you might have seen this graph before of what the various hormones look like in the different weeks of pregnancy. The main takeaway here is that you have this thing called HCG at the beginning of the pregnancy. This is what we use for pregnancy tests. And what HCG does is very simple. It's basically just LH. If you look at the different structures of FSH, LH, HCG, all these gonadotropins, they're all peptide hormones, but you'll see that the structures of LH and HCG are practically identical. You can think of them as interchangeable in terms of their effects. So HCG is just luteinizing hormone from the placenta. And what it does is it supports the luteal body to continue making progesterone so that we can keep having our pregnancy. Eventually, even in pregnancy, the luteal body does degrade and the progesterone production gets taken over by the placenta. But the main takeaway here is that HCG is equivalent to LH, except that instead of coming from the pituitary, it comes from the placenta. And this is what supports the luteal body to keep making that progestational hormone. Wow, in just a few minutes, we covered all of the things that you need to know as an MS1 about the menstrual cycle. Now we're going to talk about IVF, in vitro fertilization. You've definitely heard about this before. Let's review why you might be getting this. So maybe you've got bad fallopian tubes that are scarred or have been removed surgically. So now it's no longer possible for an egg from the ovary and sperm from the vagina to unite in the fallopian tubes and for fertilization to occur naturally. Or maybe you have low ovarian reserve because of advanced maternal age and you've been trying to get pregnant and it's just not happening. Maybe there's a problem with the father's sperm and the sperm are unable to fertilize an egg in the natural way. So now what you're going to do is you're going to find an REI doctor. That stands for Reproductive Endocrinology and Infertility, and you're going to ask for IVF. Now, what you know about IVF is probably what you see in this figure that I just drew. You get sperm from dad, eggs from mom, mix them, and then put the fertilized egg in mom. In reality, it's a lot more complicated than that. The sperm component is easy. You simply give dad a cup and a locked room, tell him to ejaculate into the cup. Easy. But unfortunately, for eggs, we can't just give mom a cup and say, ovulate into the cup. This doesn't work for a lot of reasons that I won't go over. Instead, IVF looks more like this. There's lots of steps. Ovarian hyperstimulation, transvaginal oocyte retrieval. We're going to go through this step by step and reinforce the roles of different reproductive hormones in the process. The first step is we need to mature a lot of follicles so that we can harvest multiple mature eggs. Sometimes around like a dozen eggs are harvested, so we need to get a lot of follicles going. This step is called controlled ovarian hyperstimulation. Our goal is to induce the simultaneous development of about a dozen different follicles so that we can collect and fertilize all of those mature eggs. Now take a quick moment and ask yourself, if I were a researcher trying to come up with a drug to cause ovarian hyperstimulation and stimulate a lot of follicles, what would I do? Well, it turns out that it's pretty straightforward. We are going to inject the patient with FSH, follicle stimulating hormone. It looks like this. It comes in a pen, and basically it has to be injected because remember, this is a peptide hormone. It's not something you would be able to take in a pill form. And we put it in this easy use pen because the patient needs to take this home and inject themselves with daily FSH for about 10 days. The second step is that we need to prevent spontaneous ovulation. So we're giving this patient a bunch of FSH, which is going to stimulate a bunch of follicles. If we did nothing else, eventually one or multiple of these is going to pop. And we don't want that because once these follicles, ovulate and the egg just pops out and gets released into the fallopian tubes, we can't collect them anymore. So we need to prevent this from happening spontaneously so that they're still in the follicle when we want to harvest them by needle. We need to prevent a spontaneous LH surge. Again, I want you to ask yourself, how would I do this? Well, the answer is that we basically shut down the body's natural gonadotropins using a daily shot of leuprolide. Now, what is leuprolide? Leuprolide is just GnRH, gonadotropin releasing hormone. Why don't we just call it that? I don't know. It's called leuprolide when you give it as a medication. And remember that pulsatile GnRH is what causes the gonadotropins to be released. But if you give someone continuous GnRH, it actually suppresses the release of gonadotropins. So when we give our patient a daily shot of leuprolide, it actually suppresses their normal LH and FSH coming from the pituitary gland. This prevents them from having a spontaneous LH surge and losing all of those eggs that we want to collect. Now don't worry, this doesn't interfere with the follicle stimulation because remember, the FSH is added by us. And in case you were curious, GnRH or leuprolide is a small peptide hormone and also has to be injected. We're going to inject this actually during the same 10 or 14 days when we're also giving the FSH. So this leuprolide to shut down the endogenous hormones and the FSH to cause ovarian hyperstimulation, that comprises our 2-week of modified follicular phase of the menstrual cycle, where instead of having one follicle become mature, we're making a dozen of them mature. Now, the third step is probably not very obvious. What we need to do is we actually need to have the follicles reach the final stage of maturity right before collection. And what we're going to do is we're actually going to inject our own LH surge. Now, you're probably thinking, well, that's not good. That's going to make the follicles pop and we're going to lose our eggs. Well, it actually takes a certain amount of time for that to happen. So if we inject an LH surge and then 36 hours collect the eggs, it'll cause them to mature without actually causing them to pop. So the third step is we need to inject our patient with an artificial LH surge. Now, it turns out for pharmaceutical reasons, we actually inject HCG instead of LH. And this is fine, remember, because LH and HCG are virtually interchangeable in terms of their effects. So that HCG surge that we inject is going to be just like a natural LH surge, and it's going to trigger those follicles to enter the final stage of maturity. And remember that HCG is a peptide hormone, so it also has to be injected. It looks like this. And let's just take this moment right now to review why it's called HCG. It stands for human choriogonadotropin. Long name, but it just means gonad-stimulating hormone from the placenta. It's a gonadotropin, just like LH and FSH, but it's from the placenta, which is why it has chorio in the name. Now, after seeing the first three steps, you're probably thinking that getting IVF treatment feels a lot like this, and is nowhere near as fun as the traditional way of getting poked and becoming pregnant. But don't worry, it gets better. The next step is transvaginal ultrasound-guided follicle aspiration. This happens exactly 36 hours after our simulated LH surge. The patient goes back to her REI doctor, and the doctor, using an ultrasound-guided needle hooked up to suction, pokes through the right and left vaginal fornices to get to the ovaries, where we can poke into the follicles and suck out the mature eggs. This is done under some kind of anesthesia. The next step is fertilization. Most of the time, this means simply mixing the sperm with the collected eggs, and fertilization will occur. But you could also do intracytoplasmic sperm injection if the reason for the IVF is that the sperm have a problem. After the eggs are fertilized, you let them grow in test tubes for 3 to 5 days and transfer them back into mom's uterus. This fortunately doesn't involve any needles. You just put a catheter, which means tube, through the cervix into the uterus and put the embryos in. They usually put in about 2 of them, depending on the circumstances, with the hope that one of them will become a viable fetus. But this is why it's more common to get twins when you're getting IVF. Now, there's another step here that I want you to think about. Imagine you're trying really hard to get pregnant. Is there a hormone that you would add at this step to maximize the chance of a viable pregnancy? Correct, a progestational hormone. We're actually going to give progesterone supplements right now just to make sure that this uterus is hormonally prepped for a successful pregnancy. And at this point, we're finished with the IVF portion of this pregnancy. From here on out, it's the same as a normal pregnancy. So congratulations, you now understand a detailed map of what actually happens in IVF, and in the process, you learned a lot about these hormones. I just have a few more things I want to review before we finish up. Let's return to our menstrual cycle graph. Remember 3 bullet points that I emphasized about the endometrium. The estrogen builds endometrium, causing the proliferative phase. The progesterone is what matures it, and the introduction and then withdrawal of progesterone is what kills the endometrium and causes the lining of that uterus to slough off and cause menstruation. There's a really important conclusion to be drawn from this. So sometimes we give people estrogen as a medication. It's part of birth control. Sometimes people might need hormone replacement if they have bad menopause symptoms or like osteoporosis. Anyways, if you're giving someone estrogen, there's a rule, a hard rule in OB-GYN, which is that we never ever give systemic estrogen without also giving them progesterone. And the reason for this is that if we give someone estrogen without progesterone, all we're doing is driving the proliferation and proliferation and proliferation of the endometrium without ever giving it a chance to develop and break down. So people have found in the past that if you give someone estrogen without giving them progesterone on board, you're seriously increasing their risk of endometrial cancer. Now let's review the core concepts of oral contraceptives. Birth control pills use estrogen and progesterone to suppress the gonadotropins, LH and FSH. With all of that estrogen and progesterone on board, you get negative feedback that prevents you from ever having an LH surge. You might know that when people take birth control, they typically do 3 weeks of hormones and 1 week off. You might be thinking, during that week where you're not taking any medication at all, isn't it common to have an LH surge that causes ovulation? Well, it turns out that although 1 week of placebo pills is enough progesterone withdrawal to bleed, the LH and FSH are still suppressed enough that you don't get enough of a surge for ovulation. In this graph from your slides, you can see that even though the LH increases during the placebo period, it doesn't get anywhere near the levels of an LH surge. Fun fact, you actually don't have to do this 1 week of withdrawal from your birth control pills and having your period. You can actually take hormones continuously and never have periods, and there's no negative effects of this. Most people don't do this because they prefer having their periods, or some might not realize that this is an option. Now, you've probably wondered, what happens if you were to give someone birth control that just contained estrogen without the progesterone? Well, the estrogen alone might still be sufficient to cause the negative feedback necessary to prevent pregnancy, but there's a big problem here that we just talked about. You'd be giving someone estrogen without progesterone. This would cause irregular bleeding and also cause endometrial cancer. You might have also wondered, what happens if you just give progesterone only as birth control without the estrogen? This actually works. The negative feedback is not nearly as strong as it is with estrogen combined with progesterone, so it's less effective. This is a pill that works only if you take it exactly on schedule to the hour every day. But it's a good option for people who can't take birth control that contains estrogen. Finally, let's quickly review what PCOS is. Now, there's a lot of components to the pathophysiology and treatment of PCOS, and I'm not going to cover it all here. But just to review the hormonal state that people are in when they have PCOS, they have excess luteinizing hormone. They have too much estrogen and androgens in their system. And this is actually kind of a similar state to being on birth control pills. The high levels of estrogen and androgens prevent an FSH-LH surge from happening. And that's why people with PCOS have their periods only, every couple of months and would have a difficult time getting pregnant. Here's a nice graph I found of what exactly is happening in PCOS. Even though their LH levels are high, they're not able to get that surge because of the feedback present from the estrogen and androgens. So what do we do hormonally for someone with PCOS? It depends if they're trying to get pregnant or not. If they are not trying to get pregnant, we'll put them on birth control. Why? Well, they're kind of already on this crappy version of birth control where they only ovulate every couple of months. So we're just going to take that one step further and give them enough hormonal negative feedback that they never ovulate. Putting them on birth control will also make their bleeding regular. So what about in someone who wants to get pregnant? Well, that's where we use this medication called clomiphene. What is clomiphene? Clomiphene is a drug that blocks the estrogen receptor in the pituitary. So what that does is it shuts down the negative feedback. The patient might still have lots of estrogen and androgens in their body, but the pituitary doesn't sense that. So now they're able to have the LH surge necessary for ovulation and pregnancy. Well, that's all I have. Pat yourself on the back. You're now an expert on the reproductive hormones and IVF.